Morning, ladies and gentlemen. It's my proud privilege to welcome all the panelists, speakers, and club members and invitees. It has been that a very success story for us, and we are happy that we are taking on the club as we wanted to happen. There are some setbacks because of lockdown that we could not take it in a physical form, and we have taken it in virtual form. We have even opened up because of the popular demand, virtual membership, which is hardly anything, so the right people can join in and can interact. We don't want a very big crowd for that because it is more interactive. And we are also starting a new series for knowledge webinar, knowledge series, in which we will have some thought leaders, some national, international figure who would be also invited time to time as a keynote speaker, either part of the club or off the club as a separate activity, just to see the viewpoint of the people. As you see the slide, we already have some profits, some not-for-profit activity. The conference, which is supposed to, which is a very popular one, did not happen because of the COVID issues. However, we still determined to have online. Sachin is planning all the technological part because he's organizing one for Europe on 4th of September. That's a great learning for us, and we will do it sometime in November. We are having a magazine which goes to 85,000 people. Print thing has been suspended for the time being because it cannot be circulated, and it has got some logistic issue. That has also become very popular media because this time Health Secretary has written, Deepak Chopra has written, and DG CSIR has given his interviews. So I encourage all my club members to be part of the magazine protocol of writing, also in the speaking slot during the conference. We have a special rebate for our club members. Magazine obviously is free, and these are all activity we want to encourage, that we should get our members to write, speak, and do necessary things. Since we could not do the print and we could not do physical form, we have decided that everybody is renewal of membership of the magazine and also the club. Club is alternate month, magazine is once in 3 months. We have extended renewal by 6 months. That means somebody who is due doesn't have to pay for the 6 months. After that, I presume we will be able to, the Sanjay will write directly to members and the club and to the magazine people about it. We had very successful inning very recently. We initially, Government of India gave us something which is on Ideathon, where teams came, and then came the Samadhan, and the last one, Sachin and his team has conducted a mega event which used to be face to face, and the physical form happened now online. And such a mega hackathon, he will give you the details. I thought it is of interest. A lot of people had a lot of queries. They wanted to do what it is, etc. It's the Government of India initiative. AICT is the one which was coordinating it. So we have got the good thing that we are the one who have conducted it, and Sachin have been the main on those issues. Now, I would not take much of your time. I would hand over to Sachin to give what are the challenges, what are the issues, and how he managed to do things for government, a big hackathon, which have been an issue, world's biggest open innovation model, and that is what now we have expertise, and I'm sure we'll take it forward, and Sachin will involve as many as club members as who wish to, and we will open to suggestion. Please do let us know. We want to take all this initiative, which is not for profit, with you of this club to the greater height. Thank you very much, everyone. And over to Sachin. Yeah, Sachin. Thank you.
I hope you can all see my screen. Alok, is it visible?
Yes, it is.
Yeah.
Okay. So first of all, a very warm good morning to all of you. Thank you for taking out your time. And I can say proudly that we are all part of this family. And in this family, we are almost, quite familiar with each other. But let me extend a very warm welcome to Mr. Dwivedi, who is CIO of Rajiv Gandhi Cancer Institute, Mr. Munendra, who is CIO of Lal Path Lab, and Dr. Uma Nambiar, who is shortly going to join us from Kerala. So, a warm welcome to all of you, sir. Thank you for joining us today. And as Dr. Singh said that he wanted me to share this presentation with all of you today, that how we recently organized an event where the Prime Minister of India was involved and other dignitaries. So just give me 10 minutes and I can share with you all, and maybe after that we can proceed into the panel discussion. So with your permission, let me begin the presentation. I hope my screen is visible. As you can all see that what I'm going to present right now is about Smart India Hackathon. And Smart India Hackathon is the world's biggest open innovation model, which happens every year and is organized by the Ministry of HRD. So this year it was happening at 1st to 3rd of August 2020. So I can see Dr. joined. A warm welcome, madam. Maybe you can.
Hi, thank you. Thank you so much.
Yeah. So I'm just making a small presentation, ma'am, of our recent endeavor. So which is Smart India Hackathon that we recently helped government organize. So government claims this as to be the world's biggest open innovation model because 500,000 engineering students apply to a variety of problem statements. So just to give you an imagination here on the numbers here. So there are a bunch of stakeholders involved. This year we had 40 nodal centers, meaning 40 universities were hosting it. And there were 243 problem statements from a variety of organizations, ministries, and companies. And these 243 problem statements came from 66 organizations. So including one of our own IT company was giving a AI problem, for example. So we had 1126 evaluators and 1001 student teams, which consist of 6 student members and 2 mentors. So overall, you could say there are 10,000 people involved in this activity, and this activity used to happen every year in 40 different universities at the same time. This year, of course, COVID disrupted everything. So we were asked by the ministry if we can do this virtually. So what I'm telling you is a story of 3 weeks, last 3 weeks, that our team has been busy, to understand from stakeholders how their processes work. So we designed a website, we designed processes for nodal centers, and we used for this collaboration Slack. So we created 40 workspaces representing these 40 universities and one workspace for our admin work. And in 1 week, the very first week, we trained these 40 universities, around 1,000 people, that how to work, collaborate online in the softwares that we built and the processes that we designed. And then these 40 universities organized around 60 webinars by which they trained around 9,000 people. And during the hackathon, we organized, 3 Ask Me Anything sessions. We trained evaluators, and we trained. So we also had vigilant officers. So we did some trainings for them, so on and so forth. So in nutshell, it was a lot of effort about building competence in people. So I would say that if it was not possible with the technology, we couldn't have done this program. So just very quickly, now that you understand the timeline and the situation, So very first challenge for us was, how do we, are we the right team to make this virtual? So, already in March and April, we did two similar hackathons with the ministry focused only on COVID. So one was Ideathon with 5,400 people applying. Then second was Samadhan, where the Minister of HRD was also involved. So we thought that we are kind of the right team for SIH 2020. And government originally planned this for April 2020, but they could not organize it. So they finally got the confidence with us that they could do this in August 1st to 3rd. So this was our team. So we were a 14 people team, and none of us were working in one single location. We are all working from home, but during the hackathon, at least some of us could gather together, at least 3 4 of us, but still rest of us were working. So had it not been for the COVID, for last 4 months we are not working from office. So implementing those best practices at our own level helped us bring those processes to them. Of course, we had certain risks when we planned this intervention. So uh, of course, one of them was that anybody's internet could go down, there could be technical issues, there could be a cyber attack, so and so forth. So we always thought that we need to make a decentralized approach, and we should always ask people to have a plan B. So we designed a website which allowed various things. One of them was that when the evaluation meetings were happening across nodal centers in 40 nodal centers for these 243 problem statements. So anybody from the ministry could join any of the meeting from the website, and any of the university, when they were doing the ceremonies for opening ceremonies or closing ceremonies, you could watch all the broadcasts from one single website. And then we were using Slack working spaces, so we also use Slack APIs to integrate them to our website. So website as a single point was very important to give this event shared equity for the stakeholders, and it was very important for people to feel ownership in the event. So this is just a bit on the processes that we designed and built, and this is how a Slack working space looked like. I don't know how many of you use Slack, but for example, this is a Slack working space that we built for Manipal Institute of Technology. And let's say on average a working space had around 300 400 people collaborating and solving problems. So on the left hand side you can see public channels, for example Bharat Electronics and BEML were floating their problems in MIT, and this is how students were collaborating and solving their problem statements. This is our admin
Sachin,
workspace.
just wanted
Yeah,
to make sure, are you sharing your screen? Because we are just seeing the first page of your presentation.
yeah, that's why I asked you
Yeah,
in the
now
beginning.
it's visible. Now it's visible.
Okay, so uh, I don't know if my screen was visible. Then let me just quickly show it to you. So these were just some of the numbers. This is our team that I mentioned, and this is a Slack working space that I was showing to you. And this is the website URL. It's still up if you are interested in seeing. So this is how the website header looked. And these are some of the nodal centers that you could access from the website. So if you go to the nodal center, you could actually join the meeting room. You could also see what's happening in the Slack of that working space. You could also see the broadcast ceremony of theirs. Then we designed a special evaluation module, because for AICT it was very important that they could bring out the result on time. So we designed kind of an interface that all the evaluators and all the teams can see publicly which team has been evaluated, which team is pending. And then there was also a private view for the evaluators and the nodal centers to see what score has been awarded to which team, and they could publish the report from just there itself. So this kind of technology-led effort enabled for us to bring out these evaluations in real time. and most of the people could publish their results on time. And in the last, we also wanted to have some fun. So we, during the SIH hackathon, we also run an SIH clinic, since it's a meeting of a lot of doctors here today. So we asked people to join our clinic if they had an issue, and they could pay us by selfie. So our clinic was charging them a selfie. So so this is it. I mean, in last, I could say that having done this kind of endeavor in last 3 weeks, I remember one keynote I watched on YouTube from General Manekshaw, and he said that most people are not able to do decision making on top because they lack confidence, and they lack confidence because they lack training. And I think we succeeded in this endeavor because we could train 10,000 people in 2 weeks. And once we trained them, they had the confidence. And since they had the confidence, they could make decisions that enabled this national level program to succeed. So that's it from my end. I hope this presentation was useful to all of you. And in case if you have a question, you can ask us later. But without further ado, maybe I would break in now to our actual agenda for today. And so, Alok, I don't need to share the screen anymore. We can just go into the speaker's view. So you can remove the screen sharing. Yeah. So a warm welcome to all of you again, Mr. Dwivedi, Uma Madam, Mr. Munendra, if I may request you to switch on your camera. Yeah, thank you. So thanks for joining us today. I don't know if you have any quick comment on my presentation, but I hope it is not much of a digression to our topic today. So
No, no, very well done. Congratulations. It's not
thank you,
easy to
ma'am.
carry, not easy to do something like that. Requires a lot of courage to even think about it.
Indeed, ma'am, and I think there are some people here like Dr. Tapritesh from IIIT Delhi, whose institute also won one of the prizes in SIH. So, Alok, you can give the mic access to anybody who wants, as we would want to keep it at a later point very interactive. And as you know, it's a close group meeting. So I hope until unless you have a question, you can keep yourself mute. So, ma'am, coming to our topic of the day, we want to learn from all of you expert about digital health. And I think you all agree that, like William Gibson has once said, that the future is already here, it's unevenly distributed. And in I think in all three of your scenario, you already have the future. And I may request you to distribute this future to other fellow people here. And this discussion is very important today because I was just preparing for this discussion and I learned that the Prime Minister will announce on the Independence Day the National Digital Health Mission. So I don't know if you're aware of it, but it becomes very timely because in 1 week from now, this topic will become so mainstream that the Prime Minister has to take it to the Red Fort. And of course, as other people already have mentioned in past, that Corona has not brought anything new, but it has accelerated the future into present. So if there was an adoption of any technology that has to happen, it has happened. So I believe that's a very interesting aspect, at least for me, to have this conversation with all three of you right now. So if I may request, starting with you, Dr. Uma, like 2 points that if you could share in your last 4 months, what has been your journey and any special points that you want to highlight on management challenges and initiatives that you have faced running a hospital. And also, if you could share, your readiness level to the pandemic, and how did you cope up with it? So, to start with you, madam.
Thank you so much, Sachin, for inviting me to this discussion forum. I must tell you that I am the executive director for a hospital which started in the last week of February. So you can imagine the challenge that we had just started. We were doing the finishing touches to the hospital, and COVID stuck. So we really, from whatever we had thought that we will ramp up in the first 3 months, that business plan went for us. It just, we could not, suddenly we were faced with a situation where, uh, this was really a bolt from the blue. And I think everybody was taken by surprise with the, suddenness of all the challenges created by lockdown. It was not, it was lockdown, lack of public transport, patients cannot come to the hospital. And if you remember, if you remember in the early stages, there was a lot of fear in the minds of the public also. They did not know what to do. The information to the public and the education which is related to COVID also was not enough. Having said that, so the first month literally went in, completely like thinking about how to get the patients in. Now we we have start telemedicine. We were supposed to start by mid-August, September. That was in our regular plan of things that for follow-up we'll use telemedicine. So what we did was we fast-tracked telemedicine. We implemented it from April. And from then on, we started contacting all the patients that had come and who were contacting us. And we started to implement all consultations through telemedicine. And slowly we've been seeing a trickle of things happening. But yeah, that's how it was. I mean, you get suddenly taken by a surprise which is not in your plan of things. And it starts to make you think, okay, what else can we do? So we realized that at that time, teleconsultation was the only avenue available to us. And we did a lot of free teleconsults in the beginning. People didn't know what it was all about. And more about education to people who were on quarantine used to call us, knowing what to do, when to report to us. We would call them every day just to give them support. So all of that started, and slowly things are now getting better. So that's been my experience for the first 3 months.
Thank you, ma'am. In fact, when I was writing to all three of you, I was also sharing some public news. So just to complement what you said, I think Apollo, which is a publicly listed company, has shared that in next 3 years, their OPD consultations, at least 50% of them will go online. And another interesting news was that Tech Mahindra, has launched a COVID test, a battery of COVID tests for 1,200 rupees. So it's very interesting to see that an IT player, a traditional IT large company, is getting into something diagnostics, because they believe that it's people need it with a click of a button. So I think these are interesting observations. So with that, I would like to bring in Mr. Dwivedi. You represent another large hospital, sir. So what has been your journey in regards to last 4 months?
Thank you, Sachin. Thank you for inviting me to this prestigious forum. What I see, I remember somebody quoting in one conference that if at all a cure for cancer comes, it will not come from an oncologist. Forgive me, Dr. Uma, for saying this. It will most probably come from an IT professional, because the kind of combinations and the algorithms that are required to come in for to actually decide a particular genome sequence or particular pathway blocking or accelerating or whatever, it will come from IT. It was unbelievable. But now seeing Tech Mahindra doing this, I think we slowly and slowly are coming to realize this, that this actually is a possibility. The effect that COVID has brought on digital health is almost same if I can compare to our Prime Minister's move on 8th November 2016 that brought digital money. Suddenly the physical money stopped and we just transformed ourselves into a digital economy. Similarly, we are now learning to transform into digital health. Coming to our own hospital's situation, when this suddenly struck, our very first priority was to protect our staff, our employees, then to protect our patients, their attendants from getting infected. So we thought that we must minimize the crowd, not only the patients and attendants crowd, but even our staff also. So, I'm talking more than IT, and it is all about hospital. So extending the shifts, giving more off days, giving laptops wherever were available, allowing people to work from home, so that we are not only available for longer time and longer duration, we are also having a proper plan B. So in case someone falls sick, at least somebody is there to take care of the patients and their problems. In fact, non-clinical and non-operations departments, back-end departments like IT, purchase, and HR were also lined up to take care of the front office staff's duties in case such eventuality comes. Then the next important aspect was to ensure the availability of the medicines and supplies, consumables. So that also was planned carefully. And of course, patients were afraid of coming to the hospital. So as Dr. Uma said, we also had telemedicine planned up, maybe 9 to 12 months down the line. But we had to accelerate it. Now, there were plenty of suppliers available. They were saying that they will enable us in 3 days, 4 days, and all. But the real problem is we don't want to create technology islands. Somebody is giving us telemedicine on one platform, we are running electronic health record on another platform, HIS on third platform. This doesn't really help. Integration is very important. So we pushed our HIS supplier to actually customize their telemedicine app to suit to our needs. And we worked together relentlessly. And in about a month's time, we enabled the telemedicine. Technology per se is okay, but we need to be innovative and we need to apply that ingenuity that even in absence of technology also we have something to start with. So we just created a very simple payment gateway and anyone can pay from our website, whatever amount for OPD visit is there. And we have a list of such payments. Somebody calls on WhatsApp, connects the doctor, and they are talking, and at least we started helping our patients. Then this particular app came that was only for Android. Now, the people who don't have Android phone, somebody is having iPhone or not having smartphone is a problem. So then we replicated this to the Windows environment also. Hopefully we will come very soon to the Apple platform as well. But now all these are integrated. So patients can actually talk to the doctor. They can upload their external reports taken from different labs, local labs, and our doctors can see the reports and can write the prescription online, which is delivered on the app. So patient can download and can procure medicines. We are also now planning to extend it to the at least local vicinity. If patient needs, we can send our team to collect the samples. We can send our pharmacy delivery boys to actually go and deliver the medicines also. But these are our future plans.
Thank you, sir. I think what I can gather from your points you have made, that during the initial COVID days, I think everybody was getting wiser by the minute. And there's a lot of improvisation that happened, So I think definitely the time window shrinked, So, and I could realize that how fast the things were happening, how fast the things were moving. So thank you for sharing in a very, human way your journey. So let me invite Mr. Munendra. And I think Dr. Lal Path Lab has been quite in action during the COVID time. So I'm sure your office must have been very busy, Mr. Soperna. So please share with us how has been last 4 months. Have you been able to sleep fine or lot of work?
Yes, Sachin, we slept well, first of all. It's not like that, but yes, there was a challenges, and the challenges were manifold. You can't imagine what could be the challenge for next day, because every day is a new day for everyone. We all are learning. Until now, we are learning, but challenges from the customer side, challenges from the internal employee side, challenges from the partner side, because we have a very good network from the partner side, approximately 10,000 plus partners, and they are also expecting some kind of guidelines from the organizations like us, and we are dependent on the guidelines from the government of India initiatives perspective, and we have to plan in such a way that each and everything should be well enough for considering the patient in center and employees in center. But the challenges were majorly in and around related to connectivity, because and accessibility to employees, to partners, to patients, and that particular availability and accessibility was one of the challenge from the early days of the scenarios. But when the things moving towards the next day to next day, we all were learning in such a way that yes, we have to plan in such a way that virtuality is the reality, and we have to confess from that day onwards, and how to treat our processes, peoples in a virtual environment, which will be a real environment nowadays. It's all adoption. It's all from the adoption perspective. But yes, each and everything what Dr. Uma and Mr. Devedi said to us, we also followed the same protocol. Considering patient in center, we started from e-consultation, because patient was in at their home, partners so-called doctors, because we have a doctor networks also. Doctors are in their residence. They are not talk to each other, but there were some challenges and requirement from patient side to the doctor side. We come up with a one platform with the name e-consult, so that my doctor and my patient can connect to each other, so that we can give a better service to my patient and partner. This is one of the initiative, but the next initiative related to productivity of my employees also, because employees were at their home, and we have to give some kind of tools and platform to give services back to the patient. In that particular scenario, we started customer care from home. It's just like an initiative. We transform our complete customer care department from the employee's home to my patient. They can serve to my patient from their home perspective. Another thing, we started considering from the patient side, that patient wants some kind of distance. We have a very big footfall labs in Delhi NCR and the north part of India, and patient wants some kind of social distances. Patient wants some kind of special treatment, because they don't want to touch each other. In that particular scenario, we started some kind of digital initiative related to QR code based registration, so-called point of sale registration. We started with e-walk-ins. You can done a registration, though there will be a requirement for an individual to visit my lab for the sample collection, but they don't want to be in long queue, but queue were there. But while doing that particular waiting time, they can do the registration, straight go to the phlebotomy room, give a sample and come back. It was something related to this. There was a big shift from walk-in business to the home collection business. We strengthened our fleets from the home collection verticals, and you can't imagine that it's just double within 1 month. The moment, let's assume the home collection in a day is X number of people, then it's just double within 1 month. Means we have to plan our fleet also, we have to plan our online payment journey also. These are the areas where we done some kind of digital enablement during COVID times.
Thank you for sharing that. In fact, I should admit, the only one time I went out of my home was to visit Dr. Lalpat Lab Center in my city, Ghaziabad. and
Oh,
I
I
was
see.
doing my HbA1c test, so I had that
Okay.
anxiety,
Oh,
that how will it be and so forth. So let me explain the
right.
scenario to you as a customer
Oh,
of
sure.
yours. So
Okay.
I
Sure,
went to the Rajnagar center, which you have in Ghaziabad. It's one of the bigger ones here in Ghaziabad. And I didn't find many people. There were, around the time I went there were around 3-4 people. So of course there was a sanitizer available, so I could use that. And when I made my payment using Paytm, so I could use QR code. I don't have to touch, my card, and then I could straight away go to the, section where they could draw blood. I have been always a big fan of, the blood drawing procedure because it's very painless.
Oh.
So it's been, I would say a happy moment for me experiencing your services, primarily
Mm-hmm.
because you guys send out the report on mobile. I mean, so I can avoid that second trip just to collect the report. So that
Yeah.
worked out well for me, and so just sharing that as a patient, experience. But of course, there was a lot of anxiety, that I had, and
Yeah, Sachin. Yeah, Sachin, because it's a journey from a customer, loyal customer to an advocate customer. Now you become an advocate customer for us.
yeah, I'm more than happy to share and contribute in any meaningful way. But I think your organization is one of the leading organization, and any changes that you make in your customer experience, I think they will go a long way for other Indian organizations as well. So thanks again for sharing the same, Mr. Munendra. So let me come back to Dr. Uma again, and ma'am, I believe not many people are aware of your initiatives apart from the regular hospital affairs. So I think you started a telemedicine registry for India. So maybe you can briefly, explain at least one of your favorite digital health initiative. I don't know if it could be your telemedicine registry or whatever it may be, and also maybe delve a bit deeper because most of the uh, close room meeting that we are having, the participants are quite mature in understanding of the healthcare aspects. So if you can delve a bit deeper, when you look at that initiative, what is your motivation and how do you take it further from here? So wherever what has happened in last 4 months. So over to you, madam.
Thank you, Sachin. So let me start with what is my motivation to try and spread the message through digital health. Because I feel that digital health is, digital is the technology that is going to not only help us, address the concerns that we have as healthcare providers, but it is also going to provide the ethical framework within which we have to work. And for that reason, I have been propagating digital health adoption. What is my favorite initiative? Well, it is very difficult to say because as a hospital leader, obviously getting a paperless environment within the hospital and making sure that there is 100% digital adoption is absolutely something that has been very challenging, and I definitely consider it as something that I look forward to doing, and it is a culmination of years of effort and multiple attempts at digitizing multiple hospitals. So that is one. But in the ecosystem of the digital health space, I have, as part of chairperson of Digital Health India initiatives, we started the telemedicine registry. And this was, I would say, necessitated because I saw the rush for trying to do teleconsultation, the doctors and the healthcare providers not knowing what solutions to adopt, and the solution providers trying to juggle up something overnight and to say this is what is going to answer your question, and coming to the doctors and trying to sell solutions. Now, for the lack of knowledge on either side, it became important that there is something that the doctors can, there is a something like a India Mart of telemedicine solutions, that something that the doctors or the healthcare providers could go to and see what is the right solution for us. And for the telemedicine solution providers, this becomes a place where they can go and understand what is the demand. So to have the common place where the demand and the supply providers and the seekers could meet, that was the aim of trying to do this telemedicine registry. So this is an exercise which is underway. We have done the interim report with the first 30 solutions that have been evaluated. And in another 1.5 months or 2 months max, we think that we will have done an evaluation of all the 200 applicants that we have. And it was a learning because there are, there are multiple. So we've learned that there are multiple providers who want to penetrate the tele-ICU system, tele-ophthalmology, tele-pathology. Now, this knowledge is not available to many healthcare providers. So this is an additional benefit that I think this registry would do. We are also trying to we are in fact going to announce an award for people who are producing devices that work within the telehealth ecosystem, not just all the medical devices. Those who can work in the remote space, the remote healthcare space, which is remote diagnosis, remote intervention, and remote monitoring. So this is another space that we are very interested in, and we are creating a registry of such devices. So that's another initiative that we are taking. Other than that, we have participated. We've done some, we've made some apps that can help a healthcare provider to assess what is or predict what is their likely load going to be and how to do the resource planning, which is working well in rural areas in Jharkhand. So these are some of the COVID-related initiatives that we took. But if you remove COVID out of the equation, same apps can be used for tuberculosis, HIV, any of the other public health hazards that are there in the public health space. So this is something which what we are doing as Digital Health India. So that's the other hat that I wear.
So, ma'am, just a further probe on this topic. So, one, you mentioned about these apps. So, under which initiative you are bringing out these apps? Are they available for free, or what is it like?
So that app is available for free.
Okay. So, but under which initiative?
Whatever initiatives we've done, telehealth registry, right now for the solution providers, it is for free. Because what is the aim? That to address the crisis of COVID. So this is in the national interest. It's not for profit. So we are doing this. We are all, I mean, there are a lot of professionals from the IT and healthcare industry who given their time and their effort to work on these so that we can come up with something which is in the national interest. Once the national emergency is over, then we can look at how to charge and how to really make it sustainable. But at this moment, this is entirely in the national interest and for free.
So, ma'am, if I were to just probe you further, that do you think once the COVID is over, that people will go back to normal routine, or they are converted for life now for digital? What is your opinion?
People are not converted for life, and I can tell you that the day the lockdown lifted in the beginning of June, all those patients who used to opt for telemedicine consultation, that we wanted to come and see the doctor. Some of the old people who were confined to their homes, they said, we have come to the hospital, we don't really have something wrong with us, but lockdown has lifted, we wanted to come out of the house, and the collectorate would allow them to go out of the house only if they were coming to the hospital, not to buy vegetables. So they came to the hospital. So people, so there is going to, but having said that, there is going to be a set of people who know that this is technology available to help them in times of crisis, when they are traveling, when they don't feel like getting out of home, or if travel from home is, if they have to travel long distance, they will use these technologies because they have tasted, they have understood that there is a technology. The numbers will go down significantly. Our numbers have come down to like 1/3 after lockdown has lifted. Having said that, 1/3 of the population is doing follow-ups through telemedicine. So there is a population that will still seek it, and progressively it will grow. We are a startup hospital. So we will of course have this ecosystem running in parallel, and there will be some traffic in that area all the time. But from the people's point of view, there will be some people who like it and who would prefer to use it. There'll be young, tech-savvy people, and some of the old people. I mean, we thought that old people will not adopt the technology, but some of the old people really taken to technology because they realize that they can use their smartphone to do this. So that is also there. So it's going to be a mixed bag.
I think it's an interesting debate, and I should bring in other hospital also into this conversation. So, Mr. Dwivedi, kindly share your point of view as well. First, starting with your digital health favorite, if any, and then also because you both are representing, not to say in any way less superior, but brick and mortar way of delivering care, and now you're also juggling with a new way of delivering care. So, and of course post pandemic, like Dr. Uma said, that there will be certain people who would come back to the normal their care delivery models. But I don't know if Mr. Dwivedi, you, in your dreams, if you have a virtual hospital in mind. So would you have more branches of Rajiv Gandhi which do not exist in real and they are only accessed online? So what's over to you? You're on mute, sir. Maybe. Yeah.
Can you hear me now?
Yes. It's not a good debate until unless we don't have a bit of disagreement.
No, great question. Dr. Uma and I actually are two poles in this healthcare arena. She is two opposite ends. She represents hardcore, surgical group, and that to neurosurgery. And I am a core IT person, handling investment banking, telecom, and so many models and domains, and then coming to healthcare around 10, 11 years back. We have a long history together also. So she has been a surgeon in our hospital.
Okay, good to know.
Yeah. So I had a lot of heart-to-heart conversations with her on how to ensure clinical productivity, how to make these doctors use electronic health record. There is a lot being talked about, but very little on the ground. So before this COVID struck, my entire focus was on making things paperless, making life easy for doctors, and making an integrated paperless electronic health record solution. Now, after this COVID coming, basically another dimension has come, and that is enabling the patients to consult the doctor from the comfort of their home and still keeping all the records in one single repository, one single place. So my focus was to have one single repository, one single database, irrespective of where the consult is happening. So taking to your virtual hospital concept, real benefit of telemedicine will come when we are able to really, it will be kind of hub and spoke model. It will not be a truly virtual hospital, but there will be a small place because healthcare is all about touch and feel. As Dr. Uma said, unless a patient had somebody to touch him or her and talk about and face-to-face, discuss face-to-face, that satisfaction doesn't come. And some element of this will remain there. So the small, spokes are there, small centers are there where patient can give all the vitals, can talk to a healthcare provider who is not an oncologist, not a specialist, but at least a general doctor. And that doctor can communicate with our doctors. And we maintain a single integrated record of all these consultations. Tests can happen anywhere. Reports come here. Those are integrated, form part of our graphs, our trajectories. and eventually the patient can port his or her records from one hospital to other hospital. So having an exchange sort of situation, that will be the ultimate. Have I answered your question?
Yes, I think you answered the later part well, and I will bring in Mr. Munendra also soon into this debate, because he doesn't have the legacy of defending those large buildings like you guys have, because you have a cost structure, which is heavily coming from the traditional care delivery model, and with the digital, you would not have those kind of cost structures to defend. But I still want to ask you, Mr. Dwivedi, on your digital health initiative. So any initiative you would like to highlight? I learned from your previous conversation, you mentioned about this Android app, and you're looking forward for an iOS app. And of course, the struggle of bringing the data in one harmonized format. But is there anything going on that you would like to highlight?
Yeah. So oncology is a very specialized subject. So before this, as I told you, we were working on clinical productivity. So we first took chemotherapy area, and in chemotherapy, we built kind of complete workflow where the protocols were fed into the system, and there are limited number of protocols. In fact, Dr. Uma was working on a parallel system. So we took organ by organ, starting with lung, then breast, then head and neck, and listed down the chemotherapy protocols for each organ. And then depending upon the organ, each chemotherapy protocol has so many different, chemo drugs and pre-chemo and then post-chemo, then flush. So all those were set in. Then there are formula of the calculating the doses also. So depending upon patient's body surface area, this is the recommended dose. The system automatically calculates. So all the doctor has to do is just choose a protocol, and then system does everything, and then doctor can override. Then again putting a safety net there. If doctor is overriding and something goes beyond 5% tolerance limit of upper and higher bands, system will ask a question: do you really want to do it? This is a bit of overdose or underdose for this patient, and if so, put up the reason. Then thereafter, whatever doctor is writing, doctor should not be concerned with the standard packaging of the drugs and all. Just say that give chemotherapy, this gemcitabine, 1250 milligram to this patient. Now it goes to the pharmacist in exact verbatim order, and pharmacist has the option to choose different packaging, and then it automatically goes to the nurse. Then nurse is releasing this treatment. So entire workflow, then it goes to pharmacy for the dispatching the medicine and then mixing, and then eventually having a barcode driven check that this medicine is the same that has come for mixing, the medicine, the one that was prescribed by the doctor originally, because that trace is maintained. And then finally, the medication administration chart, that too online. So we already implemented that. Then we were moving towards radiation therapy workflow. And then this COVID is stuck, and our attention got diverted to the app. And this app again came as integrated part of our HIS, so that all the records are kept in the same place. So this is how we have progressed so far. Next plans are to make this radiation therapy workflow automated, and then the surgical workflow.
Yeah, sir, good to know that you are using digital to the hilt to bring efficiency in your processes. But if you're comfortable sharing, let's say, what portion of your business uh, is coming from this teleconsult? I mean, if there were OPDs previously, is it now 10%, 20%? Do you have any ballpark figure?
In cancer, you see, the chemotherapy has to be given in the hospital.
Of course.
And this is because it is a repetitive work, Dr. Uma will vouch for it. Radiation has to be given in the hospital. So you cannot really give tele radiation. or telechemotherapy or telesurgery. It cannot happen. So it is just somebody having a discomfort, a pain, or some initial problems are there, somebody having a suspicion of cancer. Only those cases could be covered. Then follow-up consult after surgery, patient is having discomfort, or maybe after completing full cycle of radiation, if there are any after effects, only those cases are taken care of. So ideal will be 20%. Right
Okay.
now we are less than 10%.
So maybe it's fair to say that in a vertical, oriented, let's say disease-specific hospital, specialized hospital, maybe teleconsult is not going to be significant business endeavor, if that is correct to say.
See, it is a significant human endeavor. It may not be a business endeavor, but it is going to help our patients who are really stationed a few hundred kilometers away from us. They have difficulty in traveling. At least they can video chat with the doctor. They can take some relieving or palliative medicines and then come for active treatment.
So in a way, you are improving the service experience, so to say.
Absolutely.
So bringing you in now, Mr. Soparna, your business is definitely organized very much like a hub and spoke. Although in the offline world, you have a lot of collection centers, then you have bigger centers, and then you have a very large lab in Rohini. So I think you were quite well placed in terms of managing your cost, like the way a large hospital has been impacted because of lockdown. Comparatively, I don't know, maybe you are better to comment on this, but from your digital perspective, I believe I learned from Dr. Singh that he was very happy to use one of your apps. So I don't know if you would like to share with us what that app is about, because I have not tried it myself, but Dr. Singh was praising it a lot. So maybe I request you maybe 3 questions. One, if you can share about what is your digital initiative. Second, uh, how do you see the role of digital? I mean, from a business perspective in your business, like you already mentioned, home consults have doubled for you. And third, maybe what's there for you in the future when it comes to digital. Over to you, Mr. Mohan.
Yeah, yeah, Sachin. First of all, I would like to share to you that we have a top-heavy company also. We have a big setup from the infra side. We have approx 200 plus odd labs where cost is there. It's not like that they have a big setups from the hospital perspective, but we have a distributed setup which is very well in top-heavy perspective. Secondly, from the top line perspective, yes, after the COVID and during COVID, there is a dent in the top line in Lal Path Lab also. We have a non-COVID business which is on the threat as from the top line perspective, though it's a COVID business also. And managing a COVID with a good bottom line is another challenge, because there is a capping from Government of India perspective from top line, and the operation of COVID is a very expensive product, very expensive services, because we have to maintain each and every terms and condition and guidelines from Government of India, and each and every guidelines and processes is require some kind of cost. So that is a very overall business perspective from my side. From the digital initiative perspective, we have to confess that the digital definition before COVID and after COVID is completely changed. Why so? Because we have a very good strategical approach and plan for digital initiative or digital lab, and we rolled out approx 30 odd digital labs. Before COVID times, the digital labs was to, you can visualize, you can visit in Delhi NCR in few of lab of ours. Before COVID, uh, uh, we start thinking in such a way from the digital lab perspective, yes, there should not be any human intervention. We start thinking in such a way, human from the Lal Path Lab perspective. For fulfill that particular aspect, we started rolling out of our kiosk within that particular premises. You need not to have to interact with my executive, which will be a floater to that particular lab, which will be a front end executive. There will no front end in that digital labs. All kiosk, all tab enabled, and you have to intervene, or you have to interact with one person, which is a phlebotomist. Rest everything you have to do at your own way. Means it's a self-driven. If you foresee that at airports there is a kiosk, we follow the same protocol, and 30 odd labs were rolled out on the same concept. Under that particular concept, we gone with a one more step, that is the ATM. It's a report ATM. You have to visit my lab, enter the visit ID, and you can take a printout. But after COVID, all the digital norms have been changed. Why so? Because patients don't want to touch my iPads. They don't want to touch my properties. They don't want to visit my labs. That was the big shift from the mindset perspective from the patient side. Then I have to move each and every processes, features to the hands of my patients. Under that particular regime with a shorter time frame, though we have a very good plan for the patient mobile app, for B2C app, we envisage in such a way that please empower my patient to in such a way that they have to do their requirement on their own. Means under that particular initiative, there is a one app which Dr. Singh suggested to share. But that particular app for myself is not a big thing, because now each and everyone is using that particular app from the B2C Pro, Android and iOS. But for the case to the audience, yes, that particular app is take care of. You can do registration, you can do some kind of e-commerce, you can see the nearest lab, you can download your report, and that particular report is a cumulative in nature, in such a way that you can do a comparison of last 4 visits on the fly. You can there will be a one recommendation engine while doing some kind of registration. There will be some kind of AI enabled chatbots over and above. These are the high level features which we start thinking, but over and above we are coming up in a big way with a consolidation of each and every app. There will be a time that if you require fasting and PP, let's assume the normal way of Indian scenario is that my executive will visit you at 8 a.m. You have to do another request at 10 a.m. for the PP. But there could be a possibility that you give your sample at 8 a.m. at the home, and you can give a 10 a.m. PP at your office, and that particular office will be entertained by my partner. That's the flexibility we are taking care. Try to understand, we have a owned setup, we have a partner setup, we have a pickup center like hospital. Rajiv Gandhi is one of the pickup center, could be. I have no idea. I have associated with us, we have associated with us or not, but Medantas, Fortis of the world, each and every hospital is our pickup points. So consolidating each and every type of processes which required by my patient is a challenge for Lal Path Lab, because we have a multi-diversified business models. There is a price challenge from the operating side. There is a one price for lab, one price for hospital, one price for my partner, one price for my e-commerce business. So how to mitigate, how to manage that particular show with a seamless experience to the patient is a challenge. In new initiative, what we are doing, we are coming up with an omni-channel experience. Means each and every patient will be treated as a unique patient for me, irrespective of my business channels. Channels could be home collection, e-commerce, whatever it is. That's the initiative, because we were working on 7-8 different apps in the past. With this initiative, there will be a one mission, one Lal Path Lab, one app, one platform. That's the mission statement for us. Each and every process considering patient in center will be on that platform. So that's a one digital initiative we just envisage, and there are approx 4 releases. 2 releases already gone, and the recent release is related to home collection, because we have a big plan for home collection, and we are coming up with some kind of Uberization of flavors. Means there will be a flavor which will volunteer himself at 10 a.m. that I am available for 10 to 12 p.m. You can give me calls from 10 to 12, and he can download my app and do the service for Lal Path Lab in these 2 hours only. He will not be available for 8 a.m. to 6 p.m. or 9 a.m. to 5 p.m. something like this. So this is another concept under the omni-channel experience from the digital initiative perspective. One more thing which is very much related to my employee side from the digital side, that yes, we have just created a data lake from the consolidation of each and every type of data, because we have a good amount of data in terms of 120 millions of records from last 20 years. And with this initiative, because data is next you can say it's a natural resource after law. That is my punchline. Why law? It's light, air, and water. So it's a fourth natural resource as far as data are concerned. And this data will be a beneficial because we have a data. This with the initiative of data, we are giving going for a actionable data with the formation of data lake, and in that there will be a structured data. Mr. Devidi knows, and there will be unstructured data from the images perspective. And we are coming up, we are putting some kind of AIs and MLs of the technology on unstructured data. It will be in the department of histo and cyto, and that particular platform will suggest to my doctors in terms of some kind of reporting. It will not drive the report, but it will a suggestive tool based on some kind of analytics. It will be predictive in nature, and this is another initiative which we are in that particular phase. One more initiative I would like to share to you from the patient perspective, that is ETR. We follow the airlines industry. In one of the KPI airlines follow that ETA, expected time of arrival. Before starting that particular initiative, we follow airlines in such a way that we have to give an exact report to my patient with the date and time. Before initiative, there was some one statement that your report will be uploaded by 6 p.m. on or before. That was a golden statement from our side to the patient. But with this help, with the help of this initiative, we do some kind of RFM technology, some kind of forest network, neural network kind of predictive tools we built on that particular data. Now, if you are a patient giving a sample at Rajnagar at 7 a.m. based on your test, I will consolidate the logistics time. I will consider the last processing time and give you an exact date at the time of registration that your report will be uploaded by 2:32 p.m. Something like very specific. This is another digital initiative. I have a list of initiatives, but I think these are the top 2-3 initiatives I would like to share to the forum.
So I already, having saliva in my mouth because you are saying everything which is so delicious, So,
you have to visit my office. I will give you a plethora of activities for the year.
Yeah. So I have been, looking at the topic of AI for last 2 years, and whatever you are saying, I can also see Dr. Ravi Gaur has joined. I've been, discussing with him also about AI in pathology. But I would like to break 2 news with you. One is that I can see Tarak has also joined. So Tarak was one of the innovators who won in our first COVID hackathon, and he has done remarkable work with Dr. Kevin Price in US, and they're doing some chest and
You are not audible.
Yeah, so there was a bit of echo.
Yeah.
So there was a bit of echo. So anyway, so I was saying that there are quite of interesting people here in this room itself listening to you who are into AI in big way. Dr. Tapritesh logged in the morning, but I cannot see him now, but I promise you that I will announce his initiative. So he has got the first center in India funded by the government of India on healthcare and AI. So he's from IIIT Delhi, and I will see that how can we facilitate, let's say you, IIIT Delhi, and ourselves in a way that we can jointly, bring out the best. Because what is good to hear from you, Mr. Suparna, is that your vision, at least I can say, is world class. So you can bring out not just value for Dr. Lal, but you can create hundreds of global startups from India based on the asset you have, which is your data. So if that is, used in a right way, I think you can create butter. So congratulations to you on your vision.
Thank you.
And I hope, as Dr. APJ Abdul Kalam said, that dreams are not what you see when you are sleeping, but what that keep you awake. So I think you have a wonderful, what do you say, milestone ahead of you. And we as a community are more than happy to collaborate and participate. So
Yeah, and one more thing. I think Sachin, you have a good amount of quotes in your repository.
so I just like to read. So some things, they stay with us. This APJ quote is, in our office wall, because we
Okay.
really believe that. So anyway, so coming back to my last question to all of you, and after that, I would request all of our participants to ask as many questions as you want, and you should be having the mic access so you could speak directly. So last question to all three of you. As I said, this conversation today is very important because the Prime Minister is going to announce the National Digital Health Mission next week. If that is correct, what is your desire for that mission, if you were to say, and also any best practices that you would like to highlight from your last 4 months of experience from COVID. So we can start with you, Mr. Soparna, and we can go in the opposite order.
Yeah, day
So
before yesterday, Sachin, day before yesterday, I suggested 4 or 5 different add-ons to that particular guidelines.
Yes, Mr. Soparna, I think we lost you.
Yes, I was saying that day before yesterday, I suggested to that particular forum a few initiatives and few add-ons from our side to the industry. Am I audible?
Yeah, you are
Hello?
audible to us.
Yeah, you're
I think
audible, sir.
Sachin.
Yeah.
I think Sachin is having issue. You can continue, Dr. Sapanna.
First of all, I am not a doctor. Sorry, boss. Okay.
My bad.
Oh, it's okay. I was saying that I have suggested and requested to the forum that please add on few guidelines or few requests from our side as an industry player to that NDHL. That was my submission. And if you want, I can read my mails.
I think I lost you in the middle, Soparna ji. So sorry for that. But can you just say it again if you don't mind? What was your message?
Yes, I was saying that I have requested that particular forum to please add on few requests from as an industry player from our side to the guidelines.
Okay, thank you.
Yeah.
And any best practice you like to share with peers here in this group with your COVID experience?
As best practices, or you want to have some kind of insights about NDHM, what I have already shared to them?
Whatever you are comfortable sharing. So these were my
Because
2 points.
they asked some expectation from NDHM to the industry, and from our side, I requested that there must be a patient uniqueness identified from all eco channel. Secondly, interoperable model should be there, because there could be a requirement from patient side that one find I am seeing in such a way that we have a multiple credit cards, but in future there will be a one card from the health perspective, and that particular card should be accessible to Rajiv Gandhi and to Dr. Uma's hospital and to my lab also, or to a smallest nursing home. That should be accessibility to the patient side, which may come up in future because patient may ask this kind of experience. And formalization of regulatory body to ensure all the health organization comply with NDHM, because it's a requirement, because now we are following some kind of guideline from international perspective that like CAP, College of American Pathology. This is a high time that we as a player, we all should follow one guidelines which should be a government driven. Why telecom is regulatory? Because there is a regulatory guideline, TRAI. In this healthcare, there must be some guideline from the government of India perspective, and as a player we all should follow. And that is another requirement, that if I submit a data to my patient to NDHM as a platform or portal, then that particular data should be accessible to all the business partners, all the players. It's a responsibility should be to NDHM, not the Lal Path Lab. Let's assume first patient comes to Lal Path Lab and next patient goes to Rajiv Gandhi. The data should be available to Rajiv Gandhi based on NDHM guidelines and through NDHM only. It's not the Lal Path Lab's responsibility to give on the fly that particular data to Rajiv Gandhi. these are the areas I foresee to give a suggestion to NDHM. It's a long list. It will take time. Sachin, I think these are the very high level. If you want, I can read it each and every one.
Thank you, Mr. Soparna. Maybe I'll take this offline with you. So
Yeah.
thank you for sharing. So Mr. Dwivedi, do you want to go next?
Patient health record portability is of paramount importance. And in fact, not only hospitals, but also all the information systems provider, the electronic health record systems provider or HIS application provider, there should also be a set of standards. They should be NDHM conformant or compliant. The data structure should be drawn in a universal manner, and having a universal ID, as Maninder said, so that a copy of the data is available in that repository and can be extracted from each and every service provider pertinent to that patient.
Thank you, sir. So Dr. Uma, you have the last word then.
Yes, so if you remember, there is actually a national digital health blueprint. Okay, and I think that came about 2 years ago, and I think the country has to ultimately use that and take the objectives without in the national digital health blueprint. And this national health mission is the first step towards that. There are a lot of, there may be a lot of lacunae in the first step as we see how the mission is going to be rolled out. But as the, both Murinder and JP has said, the patient unique identifier is absolutely important. Interoperability is very important. These are some of the things that have not yet been considered in the National Health Mission. And we have been also writing papers supporting the NDHP. The other items that I think which are very important is compliance to standards. This is something which is not yet being addressed, and we need to have compliance to standards universally. We need to understand that the ultimate aim is to empower the patient. Now, if we have to empower the patient, educate the patient. Bring for them before we can hope that digital health is implemented across the country. And yes, from the domain perspective of healthcare, this must lead to universal health coverage. It must be inclusive in terms of all the healthcare providers that there are, and definitely that is much desired. So what we see is that the including all this, we should also have the common registry for healthcare providers, which I find is today difficult. Like when we are doing telemedicine, now doctors technically have to be registered in the state to practice in that state. But now when I do teleconsultation, I can give advice to a patient who's not in Kerala, who's in any other state, where I am not allowed to practice and give consultation otherwise. So we have to look at national unity. Until and unless we have a uniform system of registry of healthcare workers and a unique identifier for the patient across the country, this mission cannot succeed. So if the idea is that this mission has to be countrywide, applicable. And for that, the basics have to be put in the right place first. So that's what I want to say.
Thank you, madam. I think yes.
Yeah, one or two points I would like to add regarding this NDHM. The privacy guidelines should be in line with GDPR. That is another point we have to start thinking. Secondly, security of a patient data is also a NDHM's requirement. And I think Dr. Uma and Mr. Dwivedi will vouch me that there is a requirement from data exchange standards, because that particular standard should be driven from Government of India, because nowadays we are following HL7, someone is following API, someone is following something other protocols and technology. There must be some kind of exchange standard which everyone should follow as a player. And fourth, last point is from the doctor vicinity. Each and every doctor, it's a very tough terrain. Each and every doctor should follow some kind of SNOMED and LONIC kind of coding in their normal day-to-day affairs, because that's a very big challenge for a company like us, because each and every, we can't read and we can't understand the name of a test and name of a doctor over the prescription. If we follow this kind of best practices, then definitely there will be a good future for the healthcare provider from the accessibility and approach perspective.
Yeah, so regarding the privacy, Muninder, I think PDPA is coming now. So
Yeah.
that is more pertinent than GDPR for us.
Yes, PDPA, sir, but NDHM should follow, or GDPA should follow NDHM guidelines, because they shouldn't be in two parallel tracks. Which one we have to follow as a player, we can't comment in future. There must be some common lines here.
Yeah. See, what is also going to happen, and what I see happening, is that just because now there is a milieu of digital health, or there is, the platform is being set, and there is a field set for every digital health player to come into the fore, there is going to be a mushrooming of many different players. And if the standards are not in place, if the guidelines are not enforced by the government, and if the security related features are not enforced, we will be in for trouble. And I firmly feel that before an initiative so large as this, which is going to cover a billion plus population, is undertaken, the security framework must be in place. The standardization framework must be in place. If security is not there and standardization is not there, the confusion that will follow will be enormous. And then to undo the damage that we will do, it is going to be very difficult to get out from that. Because you can't fix it after confusion has already been unleashed in the market.
So, Dr. Uma and others, for last 5 years, at Innovation Curious, we have been promoting healthcare cybersecurity. And the latest in this endeavor, I think Mr. Soparna joined our launch of the cybersecurity program with PHFI. I don't know, Mr. Soparna, if you remember.
I can.
Yeah, so we just received, yesterday I received from the Prime Minister's office, from Lieutenant General Rajesh Pan, because he was present in both the launch and the inauguration of the program. So I think we are getting all the right encouragement after listening to all of you. My ears cannot be, saying that, it's better than music, what I'm can say after listening to all of you. So let me get an appointment with you, Mr. Soparna, right after this club meeting is over. And I think we can collaborate a lot more. But I think there are many interesting people in this room. So there is, as I said, Dr. Uma, Tarak Nagraj is an innovator. He is already writing in the chat that he wants to connect with you, organize a demo of his remote health tech for you. So you already have, and I hope if somebody is requesting contact details of all three of you, I hope I can share with them, because these are all well-meaning innovators. And
sure.
Yeah.
I'm happy to connect.
Yeah. So with that, I would invite now maybe a couple of questions. Anybody wants to make a quick comment or a question, please unmute your mic and go after one at a time. So Tarak, you want to say?
Yeah, thank you, Sachin, for the opportunity. And I'm Tarak Nagraj, and I'm the CEO and founder of Abhay Information Technology, which won the first prize in the innovation the hackathon, which was actually handled by Sachin and his team. So just have two questions actually. One of them is regarding this NDHM. which you were briefly talking about, would following HIPAA certified compliances, would it be beneficial, and would it be like covering the policies of security, and would the hospitals be more feeling more comfortable with any of the apps and devices following the you know HIPAA certified security? And second question is regarding the interoperability between the HIS systems and individual island apps. Would are HI systems in India using FHIR protocols for seamless transfer of data? And ma'am, it will be a pleasure for me to connect with you and show you more about what we have done. Our remote monitoring, we've come on press, and we've done it in a very large hospital in Pune, successfully remote monitoring COVID patients. In the last couple of months, and we are a telemedicine platform, done more than a couple thousand video consultations. Now we are doing remote monitoring through our devices and our app, and it's been very well accepted by the in Pune by the general public and the hospital. Thank you so much.
Yeah, thank you, Nagraj. Congratulations. So let me answer you about this, HIPAA compliance and the confidence of the hospitals. Now, in the failure of any other equivalent standards available in India, we tend to use these guidelines as they are applicable in the US or the European community to feel safe about them. Let me put it that way. And as far as most of the other solutions are concerned, for interoperability, FHIR is a recent, I think, or the recent usage by most of the IT community. A lot of them have been using HL7 compliance till now, but people have started using FHIR, and either of them are, hospitals will be comfortable using either of them. And I think as we move forward, I think FHIR compliance will be far more, I think we will see far more of it. A lot of solutions that I see do not yet have FHIR as their compliance standard. They still comply to HL7, and some of them don't comply to either, by the way. that is a challenge. But I think the users must know, the hospital administrators and the IT departments of the hospitals must insist on compliance on these standards. That's what I always feel. JP, what's your view on this?
No, absolutely. FHIR is just extension of HL7. If you look at it, it is a modern HL7. So some sort of compliance should be there. And you are right, there are still applications which don't even comply with HL7. FHIR is the way forward, I think.
So thank you for answering this question. And I think there is a question from Dr. Shivangi. And I don't know, Dr. Shivangi, you want to speak the question, or you want me to read it out for you? The question is as follows. She's saying how receptive the healthcare staff, especially physicians, toward these healthcare technology applications. Considering the lack of time amidst patient load, how do you motivate them, as they might don't want to lose their convenience of writing paper prescriptions?
Wonderful question.
JP, you want to go on it before I do?
Okay, sure. So there is not much choice really. Yes, it has been the convention to write with pen and paper. There are a lot of solutions coming. They give a special pen, special paper to capture the prescription and then load into the databases. So those innovations are coming, but I think gradually, as doctors are also becoming technology savvy, the online prescriptions will be the norm. See, life of the pathologists and the radiologists has already changed. They are coming to this understanding AI will eat their jobs if they don't become smarter. So similarly, the AI and other technology advances will come here also, Major problem is clinical productivity. So while they are typing, they are trying to write something, the eye contact with patient is not there. It is taking longer time. So we as application solution providers need to be smart. We need to devise systems so that there is minimal typing. There is a practice capture, learning of a particular practice of a doctor, and automatically suggest 3, 4, 5 medicines, 3, 4, 5 tests, and doctor just does take and done. That is how I think it will come. We are trying to design our applications in this way, and I think this is the future. Dr. Uma?
Shubhangi, I know from where your concern is coming. And traditionally, there is a belief that physicians are very resistant to using technology. Now, I would say this, that physicians are not averse to technology, but what they are looking at from technologies, will it make their life easier? Okay, and what is very important is that learning curve for a physician to use or adapt to the new system should be very, very short. So short learning curve, ease of use, and making life easier. If we can do this, I mean, see, if I can at the click of a button do, 5 things, I'd be happier than having to click a button 5 times. So you have to make any application user friendly. And for that, there are many, many innovations that are coming. See, I did the first paperless hospital in the year 2007, where the technology was far more limited than what we have today. Today, the applications are much smarter. They are more user friendly. There is so much more machine learning. There is speech to text. There is, pen to, you have write, and then you have those pens that are available that will convert your writing to text. And the conversion of field text or free text to data fields. These are all things that are enabling the adoption by the doctors. And it will also give them data for their use for writing their research papers, for publications, good analytics for them. This will definitely increase the conversion. And the younger doctor that is coming, the guys who are the millennials, for them, that's not a problem. The problem is people of our generation. They feel that, okay, I'm used to doing it a particular way, last 20 years, 30 years, I've done it. So what more is the technology going to give me? But once they start using it, believe me, they start freaking out at it. They really love it because it saves time. They can do their prescription from home. I mean, I give EMR connectivity at home so that there is no verbal orders for medication. People can see it on their phone or see it on their computer at home and write the orders. They can review, they can write the discharge summaries from home. So we, make it easier for them. They don't have to spend so much time in the hospital. So once you know that they can increase, once they realize that their comfort level can be increased, it will be easy to adopt. But having said that, the time it takes them to initially start using it can be tough. So in both places where I started from scratch, paperless was easy because it was just, there was no option given. But in another hospital where I had to change, so change management there, or converting all the doctors really took more than 8 months to 10 months to get them to change from paper to, the computerized system. But when you are starting a new hospital, that's the best time. Don't buy paper. So that is.
So I think Dr. Shivangi is representing PHFI, Public Health Foundation of India, and
Okay, Shiva.
as you know, so they are heavily into capacity building, and she's asking a follow-up question on this. That from a policymaker perspective, we know that there is a gap, but what step could be taken to bridge this gap so that the doctors are more aware of the technology? And like you said, of course, not every hospital can start from scratch. So there is
Yes.
a, what to say, not a green field, but a brown field. So how do you operate in that setting, like what Mr. Dwivedi might be dealing with?
Okay, so the first thing is in the documentation, in any patient's documentation, 80% of the documentation is done by nurses, 20% by the physicians. It is important that this community of the nurses and doctors is taught from medical school. They need to understand the EMR and the basics of EMR and how it makes life easier, and the essential and the fact that it is an essential part of documenting the patient care has to be taught from medical school. That is what, and I would think that that's where the policymakers need to get in. So one is from medical school, and from for the existing practitioners, how you would do it. We need to set training programs. We need to really get bodies together and to identify the people and give at least basic training, and the rest of it, enable through various training programs. And I feel that both communities need to really document. Nurses should be a major focus group, not just the physicians.
And the other thing, Dr. Uma, is different people have different levels of comfort. So for the senior doctors, I think we must have technology assisting them to record their instructions and then convert into text, or read their handwriting, or support them in those innovative ways.
Yes, yes.
So thank you for answering the questions, Dr. Uma and Mr. Dwivedi, and also Mr. Soparna for being there. I would not like to hold you for long, and maybe just invite now Dr. VK Singh. If sir, you have any observations, any conclusions that we might have missed. And I believe in our past discussion, you also mentioned that some of this we should take it to NABH. So any last remarks from you, sir?
Yeah, I just wanted to mention to you, as far as the national digital policy is, it started during UPA time, because I was member of a couple of committee along with another 20-30 people. We worked on it, and this was Ghulam Nabi Azad, who was the health minister, has approved it, but it never took off. It remained as it is. Telemedicine, again, the guidelines were in limbo, lots of cases in court, etc. It is not feasible, etc. happened. COVID has put it in acceleration. Secondly, I also compliment present government. I am not a BJP person, that they have put it on a fast gear. And July 2019, a blueprint for the digital health document was released. It is uploaded on Google. It is uploaded. You can Google out, and you can see it's a big document, and it takes a lot of concern which we are talking about today. And that's what Sachin said. Probably digital policy may be declared on 15th of August. And it talks everything, organization to infrastructure, how it is. We were not thinking health as a part. Hardly we were spending 1% plus GDP, but now we are forced to do so. And there are lots of initiatives which have come. National education policy also talks about that digital classes have to be there. And even Prime Minister spoke yesterday, all possible things. And that is what the concern that Artemis, when he started, the senior doctors like me never wanted to touch a laptop, and they started leaving. So I said, use dictaphone. So we have come a long way. It is a journey which has been happening. And this is what I presume now digital health will become one of the important aspects with the lessons learned so far. National cyber policy was supposed to be have been declared, and suddenly within a month plus a lockdown has happened, and there are a lot of new experiences have come, and those new experiences, as Prime Minister Office General Pant has already brought it, have been imbibed, and it is being modified, and soon this will also come. My last point is the IT have started a big role, and in health it is people are adopting, they are being forced to adopt. Clinicians, they like it or don't like it, gradually will get used to it, and That is one. In a other perspective, if you really see, the government is really taking head on various issues, to the extent I'm talking only which is only open to public, not otherwise, that government is going to use the AI, robotics, lasers, and also satellite thing as a disruptive way of fighting against on the eastern border. It has already been declared and it is being worked on. So all along, it has been really bad one way that we have suffered from the humanly. It is a slightly that adversity always bring better future. And Second World War, what happened, PERT, CPM came, and those industries have really developed in those countries. And similarly, COVID experience, India will develop as a winner, and health has to take a challenge. I thank all panelists, including Sachin, for a wonderful exposition. Thank you from my side.
I'm grateful to all of you, Dr. Uma, Mr. Dwivedi, Mr. Soparna. So kind of you to share your insights and patiently sharing your time with us. Thanks once again. Have a good day.
Thank you. Thanks
Thank
a
you.
lot. Thanks everyone. Bye bye.